Okay, so hello everyone, and welcome to the inaugural BRS Juniors FRCS webinar series. I'm George, I'm the current BRSJ president, and we've also got Sarah and Cheyenne, who've put a lot of work in from the committee to help get this thing off the ground. We're very excited about this as a project going forward throughout the rest of the year, and we are aiming to do a webinar once a month to coincide with our FRCS Viva course, which will happen just before the exam in November. And then we'll restart with a second batch of lectures in the new year. We're also going to be, for the first time, recording these lectures and putting them onto our BRSJ YouTube channel. So please spread the word for anyone who wasn't able to attend tonight, and they'll be able to watch it at a later date. And I guess watch it before the exam for any last minute tips. So I'm just going to hand over to Cheyenne, who's our current vice president, who is going to introduce our first speaker.
All right, thanks, George. Yes, hi everyone. I'm Cheyenne. I'm one of the trainees down in Wessex, and I'm pleased to introduce Mr. Tim Biggs, who is also a consultant rhinologist in our region. And I can say from first-hand experience, he's a fantastic trainer. He's a good friend of BRS Junior. Last year, he's been helping us with our FRCS Viva session. And I'm pleased to announce he's got a fantastic new book on Part A examination for anyone who's sitting the exam. It's a fantastic book. I would strongly recommend you to get your hands on it. And regarding this session, please make sure you send your questions to us via the chat bot. And at the end, make sure you fill in the feedback form which will be sent to you. It will be really useful for us for planning for the next session, and also you will get your certificate from that. Mr. Big's topic is on chronic rhinosinusitis and biologic update. He's in a very good place to talk about this topical biologics because they've been running a clinic for a very long time in Portsmouth. So I would like to first thank you and then welcome on behalf of BRS, Mr. Biggs.
Thanks ever so much, Cheyenne. So I'm just gonna share my screen. So can you see that okay? Yeah, perfect. So thanks ever so much for the BRS Juniors to allow me to speak today. So I'm going to be talking about chronic rhinosinusitis. And this is quite topical actually, because the update of the BRS has just come out. I wasn't involved in that process, but I've read it. The guidance is really good, super useful. I've included some of that in the presentation today about biologics consensus statement. I'll include that as well. So I've been running a biologics clinic with my colleague Steve Hayes for about 2 years with the respiratory team. So I feel like I've got a relatively good handle on the current biologics, which I'll go through today. Obviously now we have the release of Dupilumab and potentially Tezi in September, depending on what NICE say about it. I've also got a PhD in immunology, so a lot of the cytokine background stuff I feel like I know relatively well. So I'm going to delve into it. It should take about half an hour, I think, and there'll be time for questions at the end. So there's quite a lot of information in these slides. I'm happy to share the slides with anyone and everyone that would like them. So, yeah, that's it. So this is what we're going to cover. But I'll get straight into it. So defining the disease. So what is chronic rhinosinusitis? It's a chronic inflammatory, infective condition of the nose and the lining of the sinuses. It affects all of the lining of the sinuses. The polyps are a result of uncontrolled inflammation. And historically, there were two categories, patients with and without polyps. Now, in order to define someone with chronic rhinosinusitis, they have to have inflammation of the nose and paranasal sinuses, which lasts over 12 weeks, two or more symptoms, one of which must be obstruction, congestion, anterior or posterior nasal discharge, and one other potentially of facial pain and reduction and loss of smell. So you can't just have pain and pressure with a loss of smell. It has to have some obstruction or discharge associated with it. Plus, our objective evidence of inflammation. So that's either signs of polyps, mucopus, obstruction of the meatus, and or CT changes. So there's primary and secondary. Most of the etiology of polyp disease and chronic rhinosinusitis without polyps is unknown. It's thought to be multifactorial. You can have localized disease or diffuse disease. For the sake of this presentation, we're going to be focusing on diffuse disease, which affects the majority of the sinuses, rather than localized conditions, which are not outside of the remit of this discussion today. So why does it matter? So it affects a huge number of the population. So within the UK, up to 15%. Within Europe, 5 to 12% of the population will have chronic rhinosinusitis. Around 2 to 4% will have nasal polyps, so huge numbers of patients. Around 40% will have comorbid asthma, and that's where we were able to access biologics originally through a joint asthma ENT MDT. But for our patients without comorbid asthma, or for patients with relatively well-controlled asthma, we weren't able to access biologics, which caused a major issue. Revision surgery is high, so multiple studies have looked at patients through the lifetime of their condition, and the average number of surgeries is around 3.5 surgeries, and around 20% of patients will have a revision surgery within 5 years of their polyp disease. There's a united airway concept, so patients with poorly controlled asthma, poorly controlled chronic rhinosinusitis, their chronic rhinosinusitis will be driving their poor asthma control. So if you can improve one area, then you can significantly improve another area. So it's really important for the asthma team as well as ourselves as ENT surgeons. So we have lots of discussion about phenotypes and endotypes. So a phenotype is what you see. So traditionally, this was split down in EPOS 2012 into, did patients have polyps? Did they not have polyps? Since the advent of significant amounts of research looking at cytokines, inflammatory mediators, then we now understand that there's more endotypes than just, have you got a polyp, have you not got a polyp? You can break it down into multiple different endotypes, and there's a spectrum of disease. And we see that clinically. You have some patients where they have polyps, you do a full house FES, you see them back 3 months later, and there's beautiful mucosa with no hint of any polyp return. Whereas you have exactly the same phenotypic patient, they have polyps, they look like they've got severe polyps. You do an operation, they're growing back at an alarming rate. So there's a type 2 inflammatory cascade. So now we talk about, is it type 2? Is it not type 2? Now, traditionally, type 2 was more polyp driven. Non-type 2 was chronic rhinosinusitis without polyps, but now we know that it's more of an overlap than a distinct entity in itself. There's epithelial barrier injury, we think due to maybe a viral insult, a potential bacterial insult. Alarmins are released, so there's a signal of help, and that's at the higher echelon. TSLP, which is the target of Tezi, which is the new biologic on the scene, that's potentially coming out, being discussed by NICE in September, acts at a much higher level in the inflammatory cascade. And then you go down into the eosinophils, release of cytotoxic cytokines, which then drive eosinophil migration and local IgE responses. And then as a result, you get epithelial barrier dysfunction and then production of nasal polyps. So the polyps are the result of the inflammatory problem, the barrier dysfunction, they're not the disease itself. So you go in, you remove the polyps, but that's only half the battle really. It's the mucosa that's left behind that's still driving this ongoing inflammation. So type 2 versus non-type 2. So the type 2 tends to be more eosinophilic driven. Mast cells are important as well. You get bilateral diffuse edematous mucosa and polyps. They tend to be associated with asthma more readily. And the recurrence after sinus surgery is much higher. Non-type 2 tends to be interferon gamma, mediated neutrophil infiltrate rather than eosinophils, less asthma, and that tends to be more Asian-driven polyps. Westernized polyps tend to be more Th2. So how do you know if it's type 2? Well, it's difficult. I mean, we don't have many biomarkers within nasal polyp disease. We don't routinely measure many things. Normally, you see a patient with polyps, you give them maximal medical therapy. We don't normally do routine blood tests, although I've started to now, and I'll explain a little bit about that later. We'll examine them, we do a CT, and then we operate on them. So we don't have all of the significant and more complex testing that the respiratory team have. We're slightly behind the curve from that respect. So we rely on tissue eosinophilia. So you can send your polyps for eosinophils. Our hospital will not allow us to do that because they said they're not funded for it and they haven't got time. So we've tried, but they won't do it. So we're slightly restricted in our tissue eosinophilia counts. You can look at blood eosinophils, so peripheral eosinophils, to see if they're raised. And if they are raised, then that tends to be a marker of poor disease control in those patients. So that tends to be why when I see a patient with polyps, I'll send a full blood count. If they have raised eosinophils, then you already know, then you're on the back foot. And those patients are significantly more likely to relapse after their polyp surgery than those with normal eosinophils. Tissue serum IgE is also worth monitoring because that tends to give you an insight into Th2 as well. So the phenotypes you mustn't miss. So it's always worth elucidating whether there's anything else going on in these patients when you see them in clinic. Is there NERD or AERD? So aspirin exacerbated respiratory disease, now termed non-steroidal exacerbated respiratory disease. Samter's triad is the old name for it. So asthma, polyps, non-steroidal hypersensitivity. And actually, if you ask for it, then you do see it quite often. They tend to have late onset asthma. So always ask if the patient has asthma with nasal polyps or sinus disease. And if they do have asthma, ask, is it late onset? So in their 20s or later, or did it start during childhood? These patients tend to grow rapid polyps, and they tend to recur quickly after surgery. The other hallmark is obviously if they have aspirin or ibuprofen, then they tend to get wheezy, so it's always worth asking that. And it just changes the management plan. You can think about biologics at an early stage or potentially aspirin desensitization, which has its own issues. Allergic fungal rhinosinusitis, I don't see so much of that where I am. They often get eosinophilic mucin. You've got the Benton-Kuhn criteria, so it's worth kind of looking into that. EGPA is relatively rare. They do form polyps. If you've got an older patient, although the majority of patients with chronic rhinosinusitis with nasal polyps, their mean presentation age is normally between about late 30s to kind of early 60s. So actually, if you've got a patient over the age of 60 who suddenly develops polyps and they have a respiratory condition as well, then it's always worth sending an anchor to see if it's EGPA. If there's unilateral disease, although we're talking mainly about diffuse disease here, cystic fibrosis and PCD. So there can be carriers for cystic fibrosis and carrier for PCD, which means that they don't have the severity of the disease that others do. They present later, but it still might be important in their kind of etiology of the disease process. If you have children presenting with polyps, especially bilateral polyps, not antiquinal polyps, but diffuse bilateral polyps, then it's always worth thinking about CF and sending a sweat test to rule out CF. And immunodeficiency as well. Sometimes that can be an issue with mainly predominantly non-polyp patients with chronic rhinosinusitis and recurrent infections. So the assessment and optimization. So the assessment, the 4 pillars, so symptom burden, so SNOT-22 validated instrument, really helpful to gauge an idea. The recent NICE guidelines talk about a cutoff of over 50, defining severe uncontrolled disease. I have to say SNOT-22 normally is more useful as a marker of treatment outcome. So if you measure it and see what the response of that treatment is, then it works better than a pure standalone marker of how severe the disease is, mainly because it contains lots of quality of life type indicator questions. So if you have a particularly depressed patient, down and out kind of patient, then they're obviously going to score highly on the SNOT-22, not necessarily for their nasal symptoms. Endoscopy, so we measure polyp scores, so 0 to 4 per side. So 4 is touching the floor coming out of the nose, 3 is up to the floor, 2 is past the free edge of the middle turbinate, and 1 is within the medial meatus. And that is combined on both sides, so it gives you a total score of 8. Olfaction, very poorly measured generally. We don't have access to sniffing sticks, although we've ordered a set in order to upskill our biologics clinic, because I think that'll be really helpful. You can ask the patient whether they have needed loss of smell, and that tends to be what we rely on in clinic. And then imaging and blood. So traditionally we regularly do bloods, other than for IgE and RAS potentially. I think peripheral eosinophil count's really helpful. Imaging, obviously, CT is the mainstay of our management. So in Portsmouth, we've started to do what we call advice and guidance and pre-consultation CT. So if we identify patients, all patients that come into our Rhinology clinic need to come into an advice and guidance process. So the GP contacts us and we have a two-way discussion before we accept the referral. If it sounds like it's a polyp patient, so they're within the age of late 30s to early 60s, they've predominantly got loss of smell, nasal obstruction, and they may have had polyps diagnosed previously, they may have had previous FES, and we're more likely to identify those as having a scanning CT, pre-consultation CT. So we request the CT. CT has very low radiation risks these days. So the same radiation dose of a CT sinuses without contrast is the same as spending 3 weeks in Cornwall on holiday. So very low risk and safe. It allows us to see the patient once in clinic and come to a diagnosis, treatment plan. All of our patients need to have tried maximal medical therapy before they're accepted into our system anyway. So they've all tried nasal drops, benrazole as a standard, plus minus oral steroids if there's a question about polyp disease. So what is optimized maximal medical therapy? So what I tend to say is if you've got a patient with chronic rhinosinusitis, a spray is not overly effective, especially if they have polyps. Otherwise, the spray goes up and it comes straight out again. So what I tend to say is it's easier just to give them benrazole, normally as a trial for 3 months. That's what my standard practice is. 2 drops, both nostrils twice daily for 3 months. I always get them to use saline irrigation. If they have significant polyp burden, when I see them, then I accept that some patients are not going to be able to tolerate saline particularly well, but I offer it anyway, and I readily encourage the patients to use it. There's no point using budesonide within a wash if the patient's got massive polyp disease, because the idea of that is you want to treat the sinus cavities after a sinus surgery. Otherwise, you're not going to get any treatment, useful, beneficial treatment, really. But it is an option post-surgery. Short course of oral steroids. Now, the BRS consensus guidelines moving away from routinely giving patients oral steroids. We now know that there's significant side effects from lots of doses of oral steroids. There is a lifetime increased risk associated with steroids. So actually, I think if patients got grade 4 polyps, if you give them oral steroids, it's not really going to change anything massively. Our ICB do require it in order for us to get funding for FES, but it's on our advice and guidance acceptance criteria. So most patients have normally tried a course of oral steroids, but I don't give them another one. What I tend to find is, personally, if I've got a patient with really significant polyp disease, I would save that steroid dose for preoperative dosing, and I find it reduces significantly the amount of bleeding, allows you to clear the skull base so much better, and they have much better outcomes after surgery with a short course of oral steroids before their operative date. Treat comorbidities. So I always ask about asthma. If they've got poorly controlled asthma, then they could be a candidate for a respiratory biologic. Now, they're predominantly driven by oral steroid dosing. So the idea of a respiratory biologic is to stop exacerbation. It's not to treat their respiratory disease, although it might improve their asthma control. But the predominant output of a biologic from the respiratory side is to reduce their steroid burden. Weirdly, you have to give them lots of steroids before you're eligible to use a biologic. So they have to be on high dose inhaled steroids, as well as having around 3 to 4 courses of oral steroids a year, depending on which biologic you want to use. So this is the systemic steroid problem. So if you're giving people lots of steroids throughout their lifetime, then you're significantly increasing their risk of complications of steroids, of which they include osteoporosis, fracture, type 2 diabetes, hypertension, adrenal suppression, cataract, glaucoma, mood disturbances, weight gain. So really, we're trying to move away from blanket oral steroid dosing. And if someone's having repeated oral steroids, then that shows that they have uncontrolled disease and they need something else, not more steroids, but probably a biologic. So surgery and why extent matters. So this is quite significant at the moment, especially with the advent of using biologics. So the macro trial, so this is a multi-center, 3-arm, randomized, placebo-controlled phase 4 trial. The reason it's phase 4 is that's a trial of a licensed drug. Phase 3 is a trial of an unlicensed drug. So it included adults with chronic rhinosinusitis with and without nasal polyps, and it looked at endoscopic sinus surgery versus clarithromycin versus placebo, and its primary outcome was SNOT-22 at 6 months. So, and this was published in the Lancet. So, as we would hope to show that surgery is significantly more effective than medical therapy in placebo. Clarithromycin was similar to placebo in its effect, which was not very effective. So the consequence of this study is that endoscopic sinus surgery remains the standard surgical intervention for these patients. It's highly cost effective. The single kind of outlying nugget of real value as well in this study is that it showed that 8% figure of patients with uncontrolled disease following sinus surgery. So actually the patients that are open to biologics are the vast minority of the patients that we tend to see. So we're not saying biologics are going to replace everything that we do. They're a massive and important improvement in our care, and it allows us to treat some really difficult to treat patients, but it still remains the minority of the majority of the patients that we tend to see. So what counts as comprehensive sinus surgery? So my standard would be a full house FES in patients with polyps. I would open the involved sinuses, and if patients have severe polyp disease, then it tends to be most of the sinuses that are affected. So maxillary enterostomies, complete anterior-posterior ethmoidectomy, sphenoidotomy, and frontal recess surgery if indicated. Now, if patients have frontal pathway blockage and severe disease, then in my first surgery, I would advocate draft 2A. So you see the skull base right the way from the sphenoids all the way up into the frontals, maxillary cleared. And I'm a big advocate of trimming or removing the middle turbinates for really severely affected patients. I think it stops lateralization, it significantly improves their control post-operatively, and it's something that I do relatively regularly because I think I found it made a massive difference. So features suggesting incomplete surgery. So what we're saying is, if we're going to consider a biologic, then we need to assess the adequacy of the previous surgery. Now, we want to make sure that they've not had 4 polypectomies and then they go instantly to a biologic, as a full house FES is significantly cheaper than a lifetime of biologics. Arguably, it's less risky. So we would advocate them having a proper extensive surgery, and this is what the BRS consensus guideline suggests as well, before just instantly going to a biologic. There's a tool for judging adequacy. So there's an access, the Amsterdam classification of completeness. So you can get a CT and look at it, and it's allowing access into those areas. It's based similar to the Lund-Marconi score, but you're grading 0, 1, 2 for the access of medication into those areas rather than whether they're pacified or not. So it's a simple and quite effective assessment tool. And also, operation notes sometimes can over exaggerate what was potentially done during an operation. So an objective score on a CT is a better metric to use. And the extent of surgery does predict biologic response. There's multiple studies which do show actually, if you do more extensive sinus surgery, a full house FES, and you give a patient a biologic, then you're going to get a better outcome. I would also say that the converse is true. So we've operated on lots of asthma patients on biologics. Now, the difficulty with the asthma picture is they can't normally use Dupilumab as a first-line treatment in asthma, mainly because it's the most expensive biologic and therefore it's priced out of the market. So it's a second-line agent. Now, we've got buy-in from our respiratory joint clinic and respiratory team that they will give MEPO if patients have poorly controlled asthma with nasal polyps, which is significantly better than Bendra, which is what they were giving previously. And I will talk through the biologics in a minute. The difficulty is that if they're given MEPO, only a small percentage of patients will respond to it, and therefore we've done lots of surgery on patients on asthma biologics, and you get a significantly better outcome than if you operated on that patient off a biologic. For the moment with chronic rhinosinusitis, we have to do surgery before we offer them a biologic, but I'm just saying anecdotally, I've seen quite a lot of evidence that operating on a biologic improves patients significantly. So what are the biologics that we have available? So at Portsmouth, we have a really good respiratory team, good communication between ENT and respiratory. And as I say, I've been doing this clinic with my colleague for about 2 years now. And respiratory have access to a huge number of biologics. And we're slowly starting to get access to some of those biologics. Now, omalizumab, so that targets IgE. So that's for severe allergic IgE-mediated asthma. And there's a number of trials which looked at these drugs in polyp patients. So you've got polyp 1, polyp 2 study. These are all phase 3 trials. So you've got mepolizumab, which is anti-IL-5. So IL-5 is produced by eosinophils. It promotes eosinophil survival and migration into tissue. So it's very pro-inflammatory. It's associated with the high Th2 responses. And that's the Synapse trial that looked at this in nasal polyps. And it did find that nasal polyps do respond to MEPO, not quite as good as Dupilumab. But it tends to be the more severe patients more likely to have multiple surgeries, tend to respond more favorably to mepolizumab. So it is an option, but it's not quite as good as Dupilumab. Benralizumab, so that's an anti-IL-5 receptor blocker. Now you'd think that would have the same function. In my head, I'd think, well, whether it's the IL-2, IL-5 cytokine or its receptor, surely it would do the same thing. But it works really well in eosinophilic asthmatic patients. It's their go-to in patients with hypereosinophilia. So they have very high levels of peripheral eosinophils, then it will drive down that eosinophil count quite significantly. But I have to say it doesn't really work particularly well in nasal polyp patients, which is not ideal. So before we had this joint clinic, then most of the patients with polyps and asthma would go on Bendra, which wasn't particularly great for us, but now we have buy-in to switch them on to mepolizumab. Dupilumab is our best one at the moment, released for nasal polyps, which has just been licensed in February. So this blocks IL-4 and 13. And the Sinus 24 and Sinus 52 studies were the main ones that looked at this in nasal polyps. And then you've got Tezi, which acts at TSLP. So this is right up the chain of cytokines. So this blocks well above, right at the dendritic alarmin signaling kind of cascade level. So it's really well upstream. And this is the Waypoint trial, and this seems to show really good evidence as well. So why the asthma experience matters. So we take a lot of our evidence and a lot of our kind of structuring, giving biologics and monitoring biologics from the respiratory team. At Portsmouth, the respiratory team, as well as us, have 1,200 patients on biologics currently. So it's a huge number, and that requires a huge network of people to administer and monitor those patients. So it's quite a significant undertaking giving biologics. Now, Dupilumab was released earlier this year, and as of about a month ago, when I was speaking to the Sanofi rep, they had around 6 patients that had been given Dupilumab for nasal polyps, even though we have a really good functioning respiratory department and joint clinic process, we're still probably a couple of months off being able to reliably administer Dupilumab to our polyp patients, mainly because they need a huge amount of other resources. We need buy-in from other centres in order to allow us to do that. Because as a rhinologist, I don't know about everyone else, but it's a bit daunting giving all of these drugs. How are you going to monitor them? How are you going to administer them? Do you administer them at hospital and check for reactions? Do you give them at home? There's lots of things to talk about before you actually give a biologic. And I think the respiratory side is really important. So Dupilumab, Sinus 24 and Sinus 52. So these were studies looking at the effectiveness of Dupilumab, which essentially showed it was very good. Significantly improved nasal polyp score. Now this reduced this polyp score by about 2. So that means if you've got grade 4 polyps, then suddenly you've got grade 2 polyps. So they're not sticking out the nose, but they're still up to the past the free edge of the middle turbinate. So we found that actually if you've got really severely affected patients, they still often need something else other than just a biologic. So, but what we've found anecdotally again, is if you go in and operate on those patients, then they will have a fantastic outcome. So we're not saying actually a biologic is the be all and end all. I think we're saying that actually if they've had a surgery and they require a surgery to be a candidate for biologic, you're going to get so much more better outcome in those patients than just giving them a biologic alone. So this looked at a washout period as well. So in the this data here, it showed a significantly improved nasal polyp score, and you've got the same for nasal congestion and obstruction. But as soon as they finish the treatment and it washes out, it goes straight back up again. Whereas if you look at the 52 and they've given it for a longer period of time, up to a year, then you get continuous benefit. So essentially, these patients need to be on a biologic for a long time. So you can't just give it to them and stop it. They have to continue it to get the ongoing effect of the biologic. So omalizumab, mepo, bendra, they don't show particularly. Bendra is not brilliant for polyps. Doesn't, in my experience, doesn't really make much difference if patients are on polyps. It's not very good. Mepo is a bit hit and miss. So you could get good responders. So the clinic we did this week, we had one patient who was a very good responder to mepo. She was quite eosinophilic as well as allergic driven, had very high IgE as well as very high peripheral eosinophils, and she benefited from mepo. The IgE, I can always struggle to say that one. Omalizumab, the anti-IgE one basically is not very good for patients with nasal polyps, in my experience. So Tezi, this is the big one that's coming out. So NICE are currently discussing Tezi for potential release. We should hear in September, hopefully. I would imagine they would release it because at the moment we've only got a single agent. If you put someone on Dupilumab, they've got very high eosinophils, so eosinophils over 1, then you might be putting them at significant risk of hypereosinophilia syndrome. So actually we don't have any other options. So Tezi would be the best next option. It's just as good as Dupilumab, if not potentially better. So this is a aggregate of the change in the baseline total nasal polyp score of all these different agents. And we can see Tezi is just as good, if not better than Dupi. You've got to take this with a slight pinch of salt because they're all different studies. They all contain different patients. The outpoints are slightly different, but it gives us a rough idea of what the different biologics are like. Health economics. So lots of people are talking about, are we opening the floodgates to giving these treatments to everyone? Are we going to bankrupt the NHS? Again, I think from the BRS statement, it's really well written and well constructed. It talks about really optimizing the medical therapy, optimizing their surgical therapy. If they've had surgery before, making sure that they've really had a proper surgery before you consider a biologic. So I think it's less of an issue because we're not giving it to everyone. We're only giving it to a small subset. So in the macro trial, that would be that 8% group, which could be the potential for a biologic treatment. So prescribing, licensing and governance. I'm just going to go into briefly flit along this. So NICE for Dupilumab, obviously it's been released. if the condition is not well controlled, if they've had at least one sinus surgery. Now, it doesn't dictate what that sinus surgery is, although the BRS say that it needs to be an extensive or thorough surgery, and they highlight those areas that need to be opened. The SNOT-22 score needs to be at least 50, and the company provides it according to the commercial agreement. And it's nationally funded, so it's not locally commissioned, it's nationally commissioned. So you don't have to worry about the ICB restrictions, it's nationally funded. It's given subcutaneously. The patient eventually learns to inject themselves. They give it every 2 weeks. It's an add-on therapy, so they do need to continue their intranasal steroid as well as their sinus washes. So this is coming out in September, Tezi. The dosing is less frequent, so it's every month, so slightly cheaper potentially. So this might be the good one that we're looking for, and now it will give us 2 agents to use. Then the complicated bit was how we're going to choose which agent to give patients, because we have limited biomarkers in order to dictate which patient we're going to give what to. So, but we'll have to cross that bridge when we come to it. So this is just again talking about the fact that we need to really optimize our patients and undertake an MDT review if we're going to consider a biologic therapy. So the MDT process, asthma teams have huge MDTs involving lots of people and taking a lot of time. You can imagine 1,200 patients on biologics. That's a lot of MDT activity at Portsmouth. Now, the core MDT for a nasal biologic is deemed to be 2 rhinologists, potentially a specialist nurse or a specialist pharmacist, additional input from allergy, respiratory or immunology. So for us, we're teaming up with respiratory, so we'll have a respiratory consultant and 2 consultant rhinologists. We don't have a specialist nurse yet, although we have an asthma one that's just agreed to take on some of the prescribing for us. We don't have a pharmacist. But essentially, you see the patient, you then administer an MDT, you decide that you're going to dose the patient, then you dose them. Normally, first dose tends to be in the hospital, and then they have a home care service that then doses the patient, delivers all of the injectors to their home. It's like a EpiPen type injection process. And then you define a meaningful response. So then you normally measure it, well, it's deemed to be at 6 months to see whether they've improved. So has it improved their quality of life? So their MCID, so their mean clinical improvement needs to be a SNOT over 8.9, reduced polyp burden, so by at least 1 on their endoscopic score, and rescue steroids or salvage surgery. So then you can either grade them as no or poor response, in which case you may discontinue the biologic or rediscuss the MDT. Once we have Tezi, you might be able to switch them potentially. Partial response, 2 domains, or a good response, all 3 domains. And the idea is that you monitor these patients every 6 months, and then up to 1 or 2 years, then you can do it yearly. Safety and monitoring of Dupilumab. So common reactions tend to be injection site reactions, ocular surface issues. So the patient's had a history of keratitis or conjunctivitis, then it can exacerbate that. So it's always worth asking them. We tend to give them lubricating eye drops when they start Dupilumab, as they tend to get dry eyes. It can cause transient eosinophilia, so their eosinophil count will rise, mainly because it stops the influx of eosinophils into tissue from the periphery, and therefore results in a higher eosinophilic count. Now, normally this is fine. The only issue is if their eosinophils are normally over 1 anyway, and you start Dupilumab, then they might go into hypereosinophilic syndrome, which is really quite a significant medical issue, which then causes pulmonary infiltrates, pneumonitis, and can result in ITU admission and potentially death. So it's best to avoid it. Less common is the vasculitic type complications. The main ones tend to be injection site reactions and ocular surface issues. And when to stop, when to switch. So this is, again, we don't know. Once Tezi comes out, then we'll have to have a think about it. Normally, you have to get the previous biologic to wash out before you start a new biologic. Aspirin treatment after desensitization. So in patients with NERD and aspirin exacerbated respiratory disease, actually, we've moved over to biologic treatment. as they tend to be eosinophilic driven. They tend to respond pretty well to biologics. It's an easier administration process. We've moved away from aspirin desensitization. In Portsmouth, we don't have access to it. We do have a consultant in Southampton we can refer the patient over to. In my experience, it's difficult. You've got to marry up the surgery with the desensitization afterwards, because obviously they can't be on high doses of aspirin for FES. It's not going to really help. If they stop taking the aspirin for even a short period of time, they have to go right the way back to the desensitization protocol again. Can be dangerous. They get lots of side effects from it. It can be intranasal or oral, so it's tricky. It's not as simple as just desensitization. But for the FRCS, it's worth knowing about it and thinking about it. But in reality, that I think biologics an easier option. So take-home messages. So mainly define, do they have chronic rhinosinusitis? Do they meet the diagnostic criteria of chronic rhinosinusitis? Is there a phenotype or an endotype driving this? Can we do their peripheral eosinophils? Can you get tissue eosinophilia, measure that IgE to see whether they're type 2 or non-type 2? Patients responding to biologics are more likely to respond if they're type 2. Although if they're non-type 2, you may still try it anyway. Optimize before you escalate. So they need good medical therapy. Assess adequacy of the operation. So if they've just had multiple operations before, do we know if it's an extensive operation? If not, then we need to repeat this before we think about a biologic. Know the target. So at the moment, we only have access to Dupilumab, so I think that will change. I strongly think that Tezi will get approved in September, so that will give us 2 agents. Dupilumab, obviously at the moment, is the only nice approved agent. Assess response, and biologics may complement surgery. So if patients don't respond to biologics alone, then you can add on surgery, which may improve their efficacy in the future. Although you'd hope that if you did a thorough, extensive surgery initially, then you wouldn't have to repeat that once the patient goes onto a biologic. So in terms of FRCS example, so for example, in my FRCS, I did have a CRS question. So really, you've only got 5 minutes to try and give over as much information as possible, and you're going to get most of your marks from the standard thing rather than going into a massive rant about biologics. So obviously, initially, you're identifying the clinical picture, the CT findings. I would probably highlight the fact that you know the diagnostic criteria for chronic rhinosinusitis. What are their symptoms? Describe their CT. I would say in this CT, then their access score to consideration of a biologic is relatively low. This patient has significant amounts of lamella left in terms of their ethmoid. So you would consider surgery before you'd even think about a biologic. Then highlight the fact that you know about the biologics. At the moment, Dupilumab is on the market. But for this patient, and they need good medical therapy, maximal medical therapy, CT scanning, consideration of surgery, and then if they recur quickly after surgery, then you could consider a biologic therapy potentially, using all of the things that we just kind of explained and discussed as before in this presentation. These are the key references, and as I said before, I'm perfectly happy to share this with Sean and pass on if he wants to, and any questions.
Fantastic. Thank you very much, Mr. Biggs. That was amazing. Amazing update on biologics. If anyone's got any questions, please feel free to post in the chat box. You've been sent some questions by audience previously. I think most of it has been answered. I mean, you did touch on this one, but if you just could reiterate, what perioperative investigations do you do for your patients who you're considering for biologics?
So at the moment, not a lot. So we do, I mean, as we were kind of chatting about before we started, really, we although we've been running a joint asthma MDT for the last kind of 2 years, and we have lots of patients on biologics through chronic rhinosinusitis, but with comorbid asthma, we're still not in a position where we can actually give anyone Dupilumab yet. So we need to kind of get the buy-in from the respiratory side in order to administer them. We have, and it's a slow process because of funding. Obviously, it's quite a big undertaking for respiratory to take on all of our patients as well, but we've managed to get that buy-in. So it's taking a while in order to be able to administer a biologic, and that's even with 2 year head start of working with respiratory. So it's going to take a bit of while, I think, to get these biologics out. But essentially, at the moment, we do peripheral eosinophils. You don't want to be starting Dupilumab in patients with raised eosinophils, so that's a must. CT scanning, because you have to assess their access to surgery. Have they had sufficient amounts of surgery in order to warrant a biologic? We do pheno, so forced expired nitric oxide testing. So if patients have raised pheno, then they're more likely to be type 2 and they're more likely to respond to a biologic. At the moment, all of our patients, because they're through the asthma, they've all had spirometry, they have skin prick testing, IgE, as well. We don't have access to tissue eosinophilia, but we've just managed to get some funding from the respiratory team to use their lab in order to test our patients for tissue eosinophilia. So that will be an additional thing that I think would be helpful. The only other thing I would consider is sniffing sticks for olfactory function. I got Kelly to buy them the other day to be used in our clinic, and I think you managed to buy one of the
Yes.
kind of what they like expired nasal
Peak nasal inspiratory flow meters. Yeah.
yeah, so that might be helpful as well, just as an objective measure.
Perfect. There are some questions from the audience. I'm just going to ask one more question from those that's been sent to us and then hand it to George to go through the audience question. Could biologics be started at DGH? And another relevant question is, what were the main barriers for setting up a biologic clinic in your experience?
So for the first one, DGH, yes. So when it came out by NICE approval, they originally said it could only be a specialist allergy centre, which for us, we're not an allergy centre. Actually, our closest allergy centre is Southampton. Now they've rolled it out to respiratory and allergy centres. The BRS consensus statement talks about hub and spoke models. So it might be that you have a central unit. I mean, we're still a DGH in Portsmouth, relatively big DGH, but we still have authorization to with respiratory to issue biologics. But in theory, the smaller DGHs around, you could then get prescribing rights in order to give them the authority to have the blue tech form. The blue tech is the funding form that then you get the funding for national drug tariff. So in theory, you could give them prescribing rights. So there's no reason why a DGH can't prescribe biologics, but they're going to have to set everything up. And that leads me on to the second question. It's quite significant undertaking in order to set it up. I mean, already having it set up already, which took us about a year to set up the joint respiratory ENT biologic clinic, because you need PA approval, like who's going to do, where the clinic's going to run, like who's going to pay for the space, like all the investigations and everything. So it took a while to set that up. If you're starting it from scratch, then it's going to be tricky. You're going to need a specialist nurse, really. You're going to need dosing regimes, like how are you going to investigate the patients? You need pathways. So it's going to take a while. And I think that's why, I mean, it may have changed slightly now, but as a month ago, there was only 6 patients on Dupilumab for chronic rhinosinusitis nationally, around a month or so ago. So it's taking a while to get there, but we will get there. And now that they're open, we've got access to them, but it's going to take a while, I think.
Great, thank you, Mr. Biggs. There are, a few very relevant questions in the chat. So Emily Lowe has asked, considering what you talked about with the macro trial, when would you prescribe a course of antibiotics in chronic rhinosinusitis these days?
Yeah, I don't really like if I examine them, they've got really mucky discharge. It tends to be can be the polyp patients, or more likely the non-polyp patients. They've got really mucky discharge, then I'll give them a 4-week course of doxycycline. Now, I only give doxycycline. I know traditionally there was that doxycycline for polyps because it's anti-staphylococcal and it's anti-inflammatory. And then you give clarithromycin to non-polyp patients as they're less likely to be Staph aureus initiated. But the trouble with clarithromycin is there's a big Lancet paper which showed that the risk of sudden death is increased with clarithromycin. So you have to if you're going to give patients a long longer course, you have to do an ECG, looking for long QT, and it's a faff. Like, try and get an ECG in an ENT like clinic is just non-existent. So for ease, I tend to just give them doxy, 100 milligrams once daily for a month if they're particularly infected or they have recurrent infections. Otherwise, I don't give them antibiotics. And actually, EPOS 2020 moves away from routine antibiotic prescribing in our polyp patients.
Perfect. That's a yeah, excellent explanation. And then there was a question from Berad as well, but I think that question has just been answered with regards to setting up services in centres where they are allergy centres versus respiratory centres. And
Yeah,
then
yeah, it's going to take everyone can prescribe it. It's just going to take a bit of time to set it up, I think.
Jess Chapman has asked, does the first dose of a biologic need to be given in hospital or within an allergy clinic, or can it be given at home?
It can be given at home. Now, the respiratory team at Portsmouth always give it in the hospital as the first dose because they're worried about side effect reactions, which are incredibly rare, I have to say. Now, you can give it at home. So Sanofi have, as part of their biologic rollout, have offered what they call home care. So they will pay for a nurse to go and administer it to someone, and then they get the prescription sent to them and everything. So you can administer it at home. Now, trying to convince our respiratory colleagues to just start giving patients when they've always historically done it in hospital is a little bit tricky. So I suspect we'll end up initially giving it to them in hospital and then moving towards home care. But you can officially, and it's in the guidelines for NICE, you can.
Excellent. And then there's a final question, I guess, with regards to follow-up investigation. So once we've got these patients on biologics, should we be regularly checking blood eosinophils? And if so, how regularly? I knew you were
Not
talking about the sort of disease.
hyperinsulinophilia
Yeah.
syndrome. Yeah, not that regularly. So the BRS consensus document, which again I would really advocate people to read if they're coming up towards the FRCS and just generally anyway, because it's really super helpful and useful. But that tends to say give a dosing testing regime. So it tends to be like at 1 month, we'll check them and again at 3 months and again at 1 year. Our respiratory team are really would avidly avoid giving dupilumab for patients with a eosinophil count over 1. I was speaking to the respiratory consultant this week, and she was saying they've had 3 really super sick patients. One of them ended up going to ITU with pulmonary issues with hypereosinophilia syndrome. So I'd really avoid it, which is really important to work with physicians, I think, because I wouldn't necessarily know about that. Do you know, like and then we're prescribing all of these drugs that are super complicated. So you need, we're surgeons, you need someone to help you out, I think. So working with colleagues makes a big difference.
I guess that's why Tezzy will be super helpful when that comes in, because I'm guessing a lot of these type 2 polyp patients have a high eosinophil count, so they're going to be at risk of that.
Yeah, in Tezzy, it's the dosing is less, so the onus on the patient is like they're injecting themselves um, less, and and it's just if not better. So the only advantage of dupilumab over Tezzy is if the patients are really Th2 driven, so they haven't got high peripheral eosinophils, but they've got really high pheno and other markers like tissue eosinophilia, then they're probably going to be better with dupilumab than they are with Tezzy. Tezzy knocks out the pathway really high. Dupilumab's very focused on eosinophilic Th2 driven inflammation. So that's probably going to be our shift of when Tezzy comes out, how we're going to choose which patient we're going to offer which biologic.
I think there's another final question in the chat which has been answered, so you'll be able to review that when the presentation goes live on our YouTube channel. And then one final question from myself. Do you envisage that there's going to be issues with the disparity between the NICE eligibility criteria and the BRS guidelines for extent of surgery, particularly with a sort of hub and spoke type MDT setup?
It's tricky. I think, and the comfortability of people doing different approaches in different centres changes. It depends what kit they have, what their backup is. Do they have lots of experience, or are they more kind of generalists? So I think we just have to be kind of pragmatic about it and say, actually, we can't dictate that everyone's going to get a Lothrop before a biologic. Do you know what I mean? Like, we just have to say, do the as extensive surgery as you can do, and then consider the use of a biologic. The problem is, within our area, I don't want to become the biologic, like, center of, like, to have every patient, and it would be unmanageable. So you just have to, I think we have to be pragmatic and say, look, try and do as extensive operation as you can, and then you can consider a biologic. If they don't improve on a biologic, then you may consider sending them elsewhere to do a little bit more kind of extensive to get the add-on kind of factor. But I think we just have to be realistic.
Amazing. That's really sensible advice, I think. So yeah, thank you so much, Mr. Biggs. That was excellent and a great start to our webinar series. We will be sending out a feedback link via the mailing lists, and we'll be cross-checking it against the people who attended tonight, and then we'll be able to send you out a certificate. And if you've got any advice or topics that you want us to cover in the coming months, then we'd be more than happy to get that feedback. So thank you very much, everyone, and thanks again to Shine and Sarah and Mr. Biggs.
Thanks ever so much. Have a good night.
Thanks, guys.